results of Area 1 of Alice Rapp, which was looking across a very broad canvas. It was looking at the social, cultural, historical and policy contexts of concepts of addiction. And we're very pleased to be able to wave our book resulting from this work, edited by Matilda and the rest of the team, which is actually going to be published tomorrow. So it's very opportune that it's come out in time for the conference. So we're going to start now with the historical work package, and Alex Mould is going to give the presentation here. Alex is Senior Lecturer in History at the School of Hygiene and Deputy Director of the History Centre there. She's published on drug history, but also on patient consumerism, and she's now leading a team of researchers looking at the role of the public in public health. But today she's going to talk about our work in Work Package 1.
Thanks very much, Virginia. Okay, so now we've got the slides. So as Virginia said, I'm presenting work from Work Package 1. This is the package on addiction through the ages. Virginia Berridge led that work package, but we were involved with a number of other European partners, both at London School of Hygiene and Tropical Medicine, and across Europe, as you can see from the names of the people listed on the slide. So I'd like to talk to you about some of the work that we did in this work package, looking at addiction through the ages. And here we took the long view of addiction, looking at addiction concepts from the mid-19th century to the late 20th century, and at the terminology that surrounded psychoactive substance use in different European countries, principally Austria, Poland, Italy, and the UK. And what we found was there was considerable change over time and place. But by the end of the period, there was some degree of homogeneity in the language used to describe psychoactive substance use. What I want to do this afternoon is to present a brief overview of our key findings, draw out some key themes, and discuss the relevance of this long view for addiction policy and practice today. So after briefly outlining our methods and what we did, I will then go on to look at some of the changes and continuities in addiction concepts. Yeah, I don't know what's happened. I don't know if I've got control of this. Okay, thank you. So yes, what I want to do is to talk about the relevance of this long view over the addiction and then the relevance this has for addiction and policy practice today. So I'm going to talk about our methods, I'm going to talk about changes and continuities over time, and then go on to examine what this means for our understanding of expertise, science and addiction concepts, underscore some of the differences between psychoactive substances, and finally examine some of the local, national and international variations. I'll conclude by reflecting on what this history can tell us and how it can help us today. The long view of addiction has relevance for how we understand and thus deal with psychoactive substances and those who use them. So to explore the history of addiction concepts across Europe, we decided to focus on Austria, Italy, Poland and the UK and their historic entities. This represented a good mixture of countries from different parts of Europe with varied drinking and drug-taking cultures. We wanted to gain a long view of addiction through the ages, so we decided to centre on the period from the 1860s, when alcohol and drug problems first began to attract substantial interest, and then take that up until the 1980s, when drug use expanded exponentially in many countries. We subsequently broke this period up into three phases, so the 1860s to the 1930s, the 1950s to the 1960s, and the 1970s to the 1980s. We agreed that as far as possible across the different countries we were going to work in the same way and therefore hopefully make our results more comparable. For our first period from 1860 to 1930 we decided that we would focus on the medical approach to substance use and thus decided to examine one general medical journal, one specialist addiction journal, and one medical textbook for each country. We developed a list of terms used to conceptualize addiction, and then aimed to analyze the content of the medical texts and the journals that we had identified for each period. However, we had some problems accessing texts. Some sources in some countries were digitized, making searching easier, but in other countries, text remained in paper copy, which made searching time-consuming and laborious. As a result, for our second and third periods, the 1960s, 1970s, and 1980s, we decided to focus instead on policy documents. Policy documents included things like laws and acts of parliament, but also government reports and memoranda. Our change of focus was thus part practical. Policy documents were more readily available and easily searchable, but also conceptual. We hypothesized that by the 1950s, the state was playing a greater role in the development and dissemination of addiction concepts than it had done in the past. So let's take a brief look at what we found. Now, there's an extensive historiography on the development of addiction concepts, but the majority of this literature is confined to Britain and to the United States. And this has resulted in an Anglo-American interpretation of the rise of a disease-based view of drug and alcohol, and to a much lesser extent tobacco use since at least the 18th century. Much of this literature points to a strengthening of such an approach in the 19th century, where medical and moral views of drug and alcohol use came together in the notion of addiction and as what was then called a disease of the will. Little attention, however, has been paid to the history of addiction concepts away from the UK and the US. Our research sought to bring a European perspective to bear on this Anglo-American narrative of addiction history. What we found was that there was a range of concepts employed in our study countries, and these changed over time. In Austria, for instance, two distinct sets of terminology were used to describe alcohol and drug use. The first terminology revolved around substances and their isms, so alcohol and alcoholism, morphine and morphinism. But there was a second set of terms associated with drink and drunkenness. A variety of terms to describe drug and alcohol use could also be found in Italian discourse in this period. So we have terms like alcoholic psychosis and alcoholic paranoia, which were in circulation, but the most commonly used concept was alcoholism. Drug terms started to appear from the end of the 19th century, but their use was sporadic. In the Polish region, alcoholism gradually became the key term at the expense of others, but it meant different things at different times. Alcoholism was initially conceived of as an artificially induced madness of both acute and chronic nature. But by the middle of the period, the concept of alcoholism developed to include both the medical and social consequences of drinking, and later still it was seen as a mental illness in and of itself. In the UK, during the first part of the period from the 1870s to the outbreak of World War I, the term inebriety appeared to dominate. Encompassing alcohol and other drugs, inebriety later fell out of favour to be replaced with substance-specific terms such as alcoholism. So the period between 1860 and 1930 was one of great flux across Europe with respect to concepts used to describe drug and alcohol use. No single concept or concepts appeared to dominate, and though alcoholism was used in all of the countries studied, it didn't necessarily mean the same thing. Local discourses, such as that around drink and the drinker in Austria, still had a role to play. In the 1950s and 1960s, though, we start to see more homogeneity in addiction concepts across the different countries. In Austria, the domestic terminology around drink and the drinker gave way to a more international understanding of habitual drinking. Alcohol was of more concern than drugs in this period, as the drug problem was small. In Poland, too, alcohol remained the dominant concern. Early on, there was some interest in drunkenness as a social problem, but the disease concept of alcoholism began to gain purchase. The notion of alcoholism reduced the problem to an individual disorder, thus shifting blame from the structural to the individual level. In contrast, in Italy, during the period from the 1950s and the 1960s, there was much more emphasis on drugs rather than alcohol. Although Italy established specialised treatment centres for social diseases, of which toxicosis was one, Italian substance use policy at this time was concentrated on drugs and associated crime. Policy in the UK was also especially concerned with drugs, although there was an emphasis on drug treatment as well as drug-related crime. In the period studied, the majority of laws passed were on drugs compared to tobacco and alcohol. So looking across the different countries, we can see a coming together of concepts around alcoholism and addiction, although the other terms were still in circulation. International influences were also becoming more apparent, but at the same time, national differences remained. To what extent did such patterns continue into the 1970s and 1980s? Well, if we look at Austria, what we see is a reversal from the previous period. Alcohol was seen as a minor problem, whereas drugs and drug addiction came to assume greater importance. Policy focused on both drug treatment and drug control. In contrast, in Italy, we see continuity with the earlier period, where more attention was devoted to illicit drugs. Most of the laws passed focused on control of the drug trade rather than the consequences of drug use, but notions of prevention, care, public order, social concern, and international relationships all played a part in shaping drug policy at this time. A different approach to addiction can be found in Poland during the 1970s and 1980s. Here the focus was very much on alcohol, with regulations spanning a variety of topics, including treatment, drink driving, and drinking in the workplace. In the UK, alcohol, drugs, and tobacco all featured in the policy documents. Indeed, the UK was the only country in this period to generate significant legislation around tobacco. Tobacco, or rather nicotine, was seen as dependence-producing, but not necessarily addictive. A plethora of other terms were also in circulation to describe drug and alcohol use, such as misuse, abuse, and problem drink or drug use. So we would still seem to have quite different approaches across our study countries and some differences in the language used to describe substance use. How can we account for and explain these differences, similarities, changes, and continuities over time? Well, taking the long view over the period 1860 to 1980 and looking across our different study countries, we would seem to have moved away from a situation where medicine was the dominant form of expertise in relation to addiction and towards a more diverse policy community of professional actors. As drug, alcohol, and tobacco use increased and spread throughout the population, substance use appeared to present different problems that could no longer be dealt with by medicine alone. Stronger measures of control were introduced, and this brought other kinds of expertise to bear on drug and alcohol use. Such a shift is reflected in the language used to describe drug, alcohol, and tobacco use. Although there had long been a plethora of terms in existence in relation to habitual substance use, from the middle of the 20th century, a terminology began to develop that emphasised the social impact of long-term substance use as well as the danger to individual health. We should, however, be cautious about such broad generalisations. Different kinds of expertise in dealing with addiction can be found in different places and at different times. Just as there was no single terminology to describe addiction, there was no single addiction science. Plurality in addiction is further underscored if we look across the substances. A variety of approaches to drugs, alcohol, and tobacco can be found over time and place. All the countries we studied faced problems with these substances, but the nations dealt with them in a myriad of ways and accorded drugs, alcohol, and tobacco varied levels of priority. In the first period, 1860 to 1930, alcohol was the prime concern throughout the studied countries, but by the middle of the 20th century, we start to see differences emerge. In the second and third periods, in Italy and Austria, drugs were of more legislative interest than alcohol, perhaps partly because of the significant domestic production and trade in wine. In Poland, alcohol was the main concern, with drugs and tobacco attracting much less attention. In the UK, all three substances prompted policy initiatives, and tobacco was of much greater concern than in any of the other countries. The different substances also prompted different kinds of approaches. Alcohol was much more likely to be seen as a medical problem with social aspects, and drugs as a social or criminal problem with a medical dimension. But this wasn't the case in all places and at all times. Indeed, there was considerable heterogeneity in approaches to addiction at the national and local level. The differences between countries and their substance policies were a reflection of the different problems that they faced, but such contrasts also pointed to specificities in national politics and policy-making, in the policy-making process. For instance, in the 1970s and 1980s, Polish alcohol policy was a reflection not only of the need to deal with alcohol, but was also rooted in conflict between the state and the unions. In Italy, concern about corruption, the mafia, and the international drug trade meant that policy was outward as well as inward facing. National differences in policy were thus the result of national circumstances as well as other influences. At the same time, by the end of the period studied, some degree of homogeneity had appeared to have been achieved. The roles played by the WHO, the World Health Organization, expert committees on drugs, alcohol, and tobacco were examined by a separate project, which was also carried out as part of the work we did in WP1. And I don't have time to go into its findings here, but suffice to say that there are signs that the work of such bodies influenced the domestic framing of substance use. In the UK, for instance, the definition of alcoholism used in a Department of Health circular for 1973 literally took the definition that the WHO were using. So there was some sort of direct translation of concepts. So, taking the long view, I think we can observe the rise of a plethora of terms to describe alcohol and drug problems in the 19th and early 20th century. Many of these fell away by the second half of the 20th century, with some coherence forming around key terms such as dependence and addiction. Yet other terms continued to exist, and some of the new concepts also came onto the scene. Whatever the word used, however, there seemed to be a dual dimension to substance use terminology. On the one hand, there was a concept that emphasized the disease-based nature of substance use, whereas on the other hand, there were terms that stressed the social effects of drinking or drug taking. Sometimes these elements were encapsulated in separate words, like drug misuse versus drug addiction, but sometimes that term meant both a disease that needed to be treated and a social problem that required control. Such a dichotomy is also reflected in substance use policies, which have tended to have the twin aims of both helping those with drug and alcohol problems and mitigating the effect that these have on wider society. Once more, the emphasis between the different elements changes over time and place, but both can usually be found. Our research is important because it goes some way to correcting the Anglo-American bias in the history of addiction. In some ways, the continental European story was like that of the US, but in other ways it was different. These differences are important not only from a historical perspective, but also for what it means today. The long view of addiction concepts in Austria, Italy, Poland, and the UK has much to add to current debates. By pointing out the continuities and changes between countries and at different times, we can tease out more general trends. Although a degree of stability had been achieved around addiction concepts, these still encapsulate a variety of meanings that translate into different treatment and policy approaches. By understanding the history of such concepts and how and why they came into use and out of use, we can better understand the changes in addiction terminology and substance use policy today. Thank you.
Thanks very much, Alex, and for keeping to time. Now we've got 10 minutes for questions and comments, and the organisers have asked me, if you want to say anything, could you please stand up? Because it makes it, and also say who you are, because it makes it easier for filming and also for others in the audience. So, nobody wants to say anything now. Laura.
Talking about all drugs, and can you talk a little bit about opium and opiates, and obviously cocaine would have been the two major ones, I'm assuming, but also was there anything like the kind of race-based criminalization phenomenon that, again, like you say, the Anglo-American bias, that's a big part of the story in the US, and I'm interested in, did it translate into these countries?
Yeah, I mean, I can't talk for the other countries. I can talk to the history of what happened in the UK. And yes, in the 19th century, opium was seen, at least in part, as a problem of Chinese migrants, particularly in dock areas. And to some extent, the cocaine use in the 1920s was also associated with the fairly small black population and seen as an American import connected to jazz and things like that. But the racial dimension in the early part of the 19th and 20th century obviously changes over time, and according to the substance that you're looking at. It wasn't something that we found that was there in the policy documents, but that's not to say that it's not there. I mean, I have to say, in terms of the work that we did, it tended to be, it was quite sort of high level, and one of the things that comes out of the study is that we would want to do further research in all of those countries. The historiography, as I said, is fairly well developed for the UK. There are aspects that aren't, but for the other countries, there isn't very much, and we would definitely like to see more work on those countries and other parts of Europe too, to look at that comparative dimension, and race would definitely be one of the themes to pick up on.
Clarify my question. Was the criminalization driven by race-based exclusion in any of these countries the way it was in the US?
No, not to the same extent. I mean, the first pieces of drug legislation that come in the UK are in the wake of a panic during the First World War, which was loosely connected. There were some racial elements, but it was predominantly to do with the effect that it was going to have on troops during the First World War, and then that was broadened out. So it doesn't have the same racial dynamic that it does in the US, no.
Peter.
I think when you sent your presentation, I also came back to you, and I'm going to say the same question. Can you expand a little bit how you really feel in practical terms? I mean, I find this fascinating, but how can that help us better understand the way forward in terms of our understanding of these concepts and in terms of better governance?
I think it's about two things. It's about perspective and it's about context. And I think history gives us a unique, well, I would say this, I'm a historian, but a unique perspective on kind of current events. And that, I mean, to take the concept of heavy use over time, it's a new concept to describe a very old problem. There have been a number of other different attempts to describe that over time. By understanding that there have been these range of concepts and that those concepts were a product of their time, the product of different actors, different stakeholder networks, things that Rachel's going to be talking about, I think, a bit later on, I think we can start to, maybe that helps us reflect somewhat differently on our own attempts to reformulate those concepts. It's not a criticism of the concept per se, but thinking about those concepts are generated, they are part of a particular context, which comes to my second point about context, about if we've got that historical perspective, I think we can see the context of our own production of these concepts slightly differently.
Right, I think that's a good point on which to end, unless anyone has got another point they wanted to raise. No? Oh, Jacek.
Thank you very much. I am Jacek Moskalewicz from Poland. It was a hard question from Peter, and lessons from the history are not so simple to be just respond during 2 seconds or even 22 seconds. But general thing or general lesson would be that if we invent concept, as Alex said, of heavy use over time, is it purely scientific, empirical, and theoretically based concept, or there is a context in which this idea may come to the surface? We should reflect upon it. And again, from the history, we learn that whatever science invents may have unintended side effects. And again, I would come back to what I said in the beginning of this debate, that we should consider seriously whether we reframe addiction concept without any negative side effects.
Just to add to that, I think maybe when there is a new concept, there are other things going on in terms of how drug or drink or alcohol use is being understood. So that tells us something. It's a moment that's worth thinking about, that maybe we can reflect on what that means today as well.
Question for the point from the back.
He says, what bases into drop addiction texts in part 2 and 3 of your study? It would make the comparison with part 1 a better one.
Sorry, can you
repeat that?
Yes, it's a question of why were addiction texts dropped in parts 2 and 3 of the study? Wouldn't the third part be more comparable if it had been based on the same set?
Yeah, I mean, that is a slight downside, but as I explained, there were practical reasons in part why we did that, because of the problems of searching medical journals and the ease with which that, relative ease with which that could be done in some places and not in others, but also because there was a conceptual reason too, in that the debate, to some extent, it doesn't shift away from medicine entirely, obviously, but it becomes about a political and policy-based issue as well, and we wanted to capture that dimension. So yes, okay, you lose some element of the comparison across the three periods, but I think you gain this other perspective that's important.
Right, thanks. Any other point? No, well, thank you very much, Alex. And now we're going to have results reported from Work Package 2, which was led by Betsy Tom and was on the role of stakeholding in addiction. And I think it fits very well with the historical work, which is looking at some of the interests which have supported the introduction of concepts in the past. The work in Work Package 2 was very much looking at some of those issues in relation to the present and the near present, and we in fact worked quite closely together across those two work packages. And today Rachel Herring is going to present some of the results from that work package. Rachel is Senior Research Fellow at Middlesex University in London and the Deputy Head of the Drug and Alcohol Research Centre there. She's published and researched very extensively, particularly in the area of alcohol, and she's also an editor of the journal Drugs, Education, Prevention and Policy. So over to you, Rachel.
Very much like Alex, I'm presenting on behalf of the work package, and I'm going to give a brief overview, flag up some key findings, and sort of point you to where you can sort of read in more detail, which is really the book, which I would have waved, but I don't know where it's gone now. And also there's a number of papers that have been published throughout the work package, which again will sort of give more in depth, because this is going to be a quick walk, really. I won't spend too much time on the aims, but really we were looking at trying to sort of further understanding around the roles of certain selected stakeholder groups in relation to alcohol and drug policy, and to explore interactions between stakeholders, their activity and other factors influencing policy, and also to use different theoretical perspectives and really to see what was useful to contribute to the analysis of stakeholding. So we used a variety of different theoretical perspectives, which I'll try and pick up later, and key to provide a cross-national framework for thinking about stakeholder analysis. We took a case study approach. 6 countries with very different political histories and varying drug policies. And the case study approach allowed us to cite contemporary analysis within the historic context, and I think that was very important. And also allowed us to explore how stakeholder dynamics have developed and changed over time. So that the history was very important, and there was quite a lot of crossover in terms of members of the 2 work packages. So there were people working on both the history and the stakeholder one, and I think that was some useful synergies there. We used a qualitative approach as it's really the most suitable way for examining experiences and perceptions of stakeholder activity and its relevance to policy formulation and also implementation, because that's often the devil is in actually getting it to be implemented. And we did a series of case studies, and they were chosen for a variety of reasons, to reflect relatively current issues in drug and alcohol policy where there'd been visible stakeholder activity, and also some where there'd been there was conflict. So we looked at drug consumption rooms, opiate substitution treatment, and also we did case studies which allowed us to sort of explore more specific effects of stakeholder dynamics. For instance, the formation of stakeholder alliances. And we also looked at trying to explore the interaction between policy change and stakeholder activity. And so one of the things we looked at was trends in alcohol policies across countries. And we did one case study as well, which looked at the role of international epistemic communities or knowledge networks. And what the case study we did on that was looking at researchers involved in heroin-assisted treatment. We did one case study that was common across all the countries, which was on the OST, and that was the first one we did. It was a good way to get to work together and facilitated cross-national comparison. And the emphasis was on the interaction between stakeholder groups and policy at national level. We did do, obviously it did touch on sort of local and international, but that was the emphasis. As I think we've already picked up, it's a sort of very crowded space, and that's not exhaustive at all. It's just to sort of give you an idea of the diverse sort of actors. And the number of stakeholders in the addiction fields has increased dramatically, partly some of the things we were talking about earlier, but it has more behaviours have been problematised and as addictions, such as excessive gaming or internet use or sex or shopping even. And also that because there's been a growing emphasis on democratic governance approaches that promote the participation and devolution of power to municipal and local levels, and that widens the stakeholder groups who have some opportunity to become engaged at some level. Right. As with most terms, there is no consensus definition. And the concept of stakeholders is actually rooted in business science literature, but since the 1990s has been prominent within political and policy discourse. And from a discussion with partners, it was quite clear that it wasn't the only term that was used. In fact, not always, some countries, it wasn't really the dominant term. And another key term was interest group. So that was, we sort of worked with those two terms, really. We adopted this broad definition, which stresses the power to influence an organisation regardless of legitimacy. There are some narrow definitions which tend to emphasise the legitimacy of stakeholder claims, but we thought it was important to take this broader. Another reason we took this definition is that there's a distinction in conceptualisation between stakeholders that affect a policy organisation and stakeholders that are affected. They're not mutually exclusive, but they're not necessarily connected either. As I said, we were trying to use a number of different theoretical frameworks, and one of the ones that we used, which turned out to be very useful, was sort of drawing on John Kingdon's classic work on agenda setting processes and the idea of a policy window. And so these windows of opportunity. There's been work done in the past, Simon Lenton on drug policy, and I just sort of paraphrase him, is, you know, that these windows of opportunity for drug policy change they're open sort of infrequently. They're there for a short time and then they shut tight for a long period. So they're there, but they're there. And it's a time where the existing stakeholders can increase their policy salience, and there's a reframing. And I think there's a good example from Poland, which is where the economic and political changes post-1989, which coincided with the HIV epidemic, produced one of these policy windows in which new international stakeholders, such as the World Health Organization and the UNODC, and later the EMCDDA, could influence and support a harm reduction agenda. But we have to remember that it can be very difficult for these new stakeholder alliances to compete with established groups. Another theoretical framework we found useful was Karen Brackstrand's work on framework for civic science, and these concepts of representation, participation, democratisation come from her work. This framework was used to explore if and how user groups are involved in policy processes in 4 countries, Denmark, Italy, Austria and UK. I haven't got time to go into the detail, but basically highlighted very different traditions for involving stakeholders in the policy process and the inclusion of drug users in the policy process. Denmark and UK have actively engaged users in policy developments for the past decades, where in Austria and Italy, they don't have established mechanism for involving users. So there does seem to be some sort of movement within Italy. But in Denmark and UK, there still quite limited windows for these processes to emerge and develop, for instance, the HIV crisis. And even with this involvement, it doesn't mean to say that representation and participation is either unified or necessarily results in democratization, so that there are, again, problems about that level of engagement and the power that they may be able to influence, they may be able to have. Other very key, two sort of different sorts of invisible stakeholders. The vulnerable, less powerful groups, the users and their families, and they're sort of a sort of relatively new category. But the other group are those that are working behind the scene. And the work we did on the recovery debate in the UK and on the sort of challenging of method and maintenance, the civil servants and government advisors, although they were less visibly engaged in the debates, they played very key roles in moderating the debates around the role of method and maintenance and ensuring that an sort of extreme policy of total absence did not appear in the published drug strategy. So that there are very different sorts of invisible stakeholders that need to be remembered. Throughout the case studies, we were interested in how stakeholders both use and produce knowledge and evidence, and thinking about what counts as what counts as expertise, who counts as an expert, and what counts as evidence, and who decides. So all those questions came through. I think, again, with there has been some acknowledgement of the need to broaden out the evidence and what counts as evidence in terms of thinking about the lived experience of the user and the knowledge-based expertise of practitioners. But really, throughout the study, it became very evident that accepted evidence, it remains really that scientific evidence, you know, the power of the RCT and the meta-analysis. And it's very difficult for that to be challenged. I would need probably a whole day to cover that. And very much, as with the history work, that the importance of external forces and stakeholders, and particularly sort of the big international stakeholders, and both in terms of sort of external frameworks, the EU directives, the UN conventions, but also the stakeholders, the foreign governments, international agencies, and some of the sort of large NGOs. And I think particularly that came out was the importance of the UN agencies, and I think has been sort of flagged up. And so, for instance, in Denmark, although there were discussions in the 90s about the provision of safe injecting facilities, the UN and the INCB really put some pressure, and the Danish bureaucrats resisted the provision of safe injecting facilities until 2012, arguing that the UN Convention, as the UN Convention sort of argued that heroin was not to be used in treatment for addiction, such facilities would be a violation of the Danish obligation to the Convention. And again, the role of the US as a powerful sort of guardian of the UN Drug Convention came over quite strongly, and that they would use their power to convince less powerful countries to sign up to conventions and demand observance. I think Austria was a case in point. And also by the export of the drug policy model. Again, in Denmark, having had sort of 35 years of depenalisation of cannabis for personal use, the sort of war on drugs was used to legitimise a shift to a more punitive approach. So what are the implications of the work that we've done? I think, again, perhaps sort of in sort of similar ways to some of the history work, it's about remembering the importance of context and difference, and that you need harm reduction strategies which can be adapted to address the issues posed by the use of different substances. You know, that drugs, alcohol, tobacco, they're different, and that needs to be remembered. And also they're used in different ways by different people living in a variety of socio-economic and political contexts. And responses need to be adaptable and be able to respond to changes in the landscape, whether that they be political, economic, or new drugs on the block. And I think as such, policymakers need to be inclusive in considering the policy preferences of different stakeholder groups. It needs to be a very broad church. And in terms of sort of future research, I think that, I mean, we did focus primarily at the national level, but I think it would be important to really try and sort of examine stakeholding at all levels of governance and the articulation between, or not, between those various different levels of governance, and the impact of those interactions, or again, those lack of interactions. So I think that would be one area that would be useful to take forward. And I think from the work package, I mean, it became apparent that analysing cross countries and substances is, I mean, it's challenging, but it's worthwhile. So, and there's plenty of opportunities to take that work further. And shameless plug of the book, which is published tomorrow, so that's good. And as I said, where these issues are developed with in much greater depth, and I think that there's a lot to be gained from reading those sort of detailed case studies. I think it's a good way they're applied, and I think can bring those quite complex concepts to life, really. So thank you very much.
Thanks very much, Rachel. Now, any comments, questions? Alison.
Thanks very much, Rachel. So we kind of take a normative position, I think, that engaging with multiple stakeholders as part of the development of new policy and then policy implementation is important and results in better outcomes. Well, okay, I have a normative position that the engagement of multiple stakeholders in policy processes results in better outcomes. But I realise I don't have any evidence to support that. Across your multiple cases and analyses, was there any evidence that suggested that actually policy was better when stakeholders were engaged?
I think that probably the areas where you got perhaps some very innovative work and was particularly around the HIV and the facing that crisis, which did take on a very broad range of stakeholders, and people did sort of think in imaginative ways, and policies were put forward and interventions which some people, and in some quarters weren't accepted, but that was very innovative and have been. And now, have proved the test of time, really. And that was a sort of an example of that policy window and people working, being able to work together to tackle that particular issue at that time and come up with, things like, the whole thing about safer injection and actually sort of saying, well, we're not going to stop people injecting, we're going to make it safer for them, and, that is going to have good outcomes, not just for them as an individual, but, in terms of public health. So I think that there are examples, but they're probably... they're memorable because there aren't so many of them, I suppose. There's sort of certain times that.
Peter? Multiplicity.
Spoiled for choice.
I mean, I guess it depends also what stakeholders. I mean, did you do an analysis of different stakeholder groups and the power of different stakeholder groups? I mean, in other areas of the work, we've been kind of struggling of, you know, how do you manage big vested interests that are stakeholder groups that don't end up dominating the policy discussions just because they have much more power than other groups, i.e. the private sector?
Well, I think the other group that have a lot of power are government, and which I think sometimes gets lost, really. There's sometimes we focus on the corporations and we don't always remember the government stakeholders that do wield a lot of power, and certainly within the sort of the UK debates, you know, that work behind the scenes was very important. You know, in terms of the civil servants and those sort of policymakers who, you know, quietly, but they're not very visible. I mean, we didn't specifically look at the sort of power dynamics, but I think we looked perhaps more at the power dynamics of those who have less power in terms of things like the user groups, and that sometimes that although they are being and certainly again there was evidence that people felt that although they were being brought to the table, they really they didn't have very much influence and power, and so that was quite a strong feeling that came through, not just from people who were from those groups, but actually from sort of people from the outside could see that you know, that it was participation, but perhaps not democratisation.
Can I just have one quick
sure.
follow-up? I mean, it's really, I suppose I'm challenging one of your statements on one of your slides, which said that we should be very inclusive in the stakeholder groups. And whilst, yes, I agree with that, I think there are issues to be resolved around, you know, the rules of the game of who are the stakeholders in the relevant part of the policy process and how do you manage that. And I mean, there was the whole of the Jonathan Gornall stuff in the British Medical Journal on the, you know, the impact of the alcohol industry in terms of policy decisions and outputs, both at UK and European level, demonstrating that maybe the rules of the game had not been clearly sorted out before that stakeholder involvement, which led to change in policy that was perhaps more in the interests of the corporate interest than in the health interest.
Robin.
Yeah, this is observing from partly from outside in terms of going to the, you know, CND meetings and so forth. It seems to me that Europe in this period, the European Union members were trying to figure out how to work better together around drug policy. And that, in fact, places like Sweden, which has a very tough drug policy, somewhat compromised with the rest of Europe around it. Yeah, and I think in other areas, other countries, might be able to find the same thing. Were you seeing evidence of that in your, of that kind of level working its way out at your stakeholders at the national levels, or was it not something that came through?
In the sense that, can you just, sorry.
So that there was some kind of convergence, which was a sort of purposive, let's try and figure out a European stand on drug policies rather than each country having its own, so to speak. To what extent did that show up at all?
I think we probably that didn't, and I'm struggling to remember that coming out strongly.
Okay. Yep. Yeah, which is quite likely that in the context of when they're all sitting together in Vienna, then they're making that language. But
yeah, no, I think that's something that. I know that people are learning from each other, but I think that, as you said, they're not sort of converging to a common sort of. And those things change. There's lots of shifts over time, and countries can take quite different approaches as as picked up in different points of time, and that may be to do with the political dimension, and certain governments coming in on a particular agenda and changing the policy. But obviously those governments will move on, be elected out, and another you can get quite a shift over time. But yes, no, I don't. That's certainly. I'm racking my brain, but it certainly isn't.
Do you mind if I say something from the history?
Yeah.
We did look at this a little bit in the history work package, but we didn't present it today. We looked at the language at the international level, and in particular WHO and the ICD definitions. But what also came on into the picture very much towards the end of the period is the role of an organisation like EMCDDA, presenting not international definitions, but kind of rather a different standardised terminology, which all countries in Europe are starting to use and to operationalise. So I think there is that European dimension, but it probably didn't come into what you were looking at in quite the same way, did it? But it certainly was something that we looked at, didn't we, Alex, in the historical work. So that was more contemporary history. Anything else? No? Well, I think our time is up for that. Thank you very much, Rachel. And now we have the final presenter, who is Matilda Hellman from the University of Helsinki. And Matilda, as well as being at the University of Helsinki, was the overall leader of the area which we were working on, and also running one of the work packages herself. So you had a big task to carry out. And today, and she's also the main editor of the book, which we've just published, and done a huge amount of work on that. So today she's going to look at the divergence and the overlap between popular and professional narratives.
So I want to continue this session's theme and speak about what we can learn from studying variations in perceptions of addictive behaviors. And the past 5 years we have studied how such problems, their solutions and their severity are apprehended in different countries. We studied popular understanding in the media, and we surveyed also lay people. But we have also interviewed welfare professionals, GPs and social workers, and on the basis of these inquiries we can summarize some knowledge that I think is very valuable. And I try to squeeze it into this presentation, but before I start I want to remind you that I'm now painting with a very broad paintbrush, so I'm making a lot of generalizations. The studies are more complicated and there are more details that I should mention, but I don't have the time. How do I? Maybe this? Oh, maybe it's in the wrong way. Okay. So what do I mean by popular and professional images? What are they? When I say the word images, I refer to understanding and ideas and perceptions, not pictorial images. And on a general level, one can first say that there are all kinds of images that we have studied are institutionalized and script. And that means that they are cultural material. They stem from different historical developments and circumstances, and they have been developed and progressed within institutionalized setting in modern societies. And this, of course, includes also institutions of knowledge production. So in that way, they are script. It's hard for ideas that differ very much from these expected and mainstream ones to penetrate the general consciousness and receive salience. the ways in which these problems are presented by the media and professionals, they follow certain patterns. They vary between countries in certain ways, and these variations I find very interesting. But it's also important to remember that the ideas about the problems will always, to some degree, represent certain angles on the problems or interests of some sort. So if you want to, you could use the word political to describe that. With that, I mean that it's embedded some kind of worldview on how to treat them and what they are all about. So we studied press materials from 7 countries, professional images from 3 countries, and we surveyed lay people's images from 5 countries. And we looked at how these categories of materials, we asked our materials how they understand addictions or addictive behaviors. I'm going to summarize some general traits that are true for all materials, and then also some things that make them differ a bit. So if we look at the media material, there are some general trends that are true for all. Again, this is with a very broad paintbrush on brushing, but we could see a shift from social framing to the individual problem holder as the site of the problem in the portrayals. And this also shifted a bit the conceptualization of the responsibility division, that if the individual is the one who makes wrong choices and causes the problem for themselves, then the responsibility for the solution repertoire will, of course, also be attached to that unit more stronger. Also, there were a shift towards increasingly detailed physiological accounts. This is also part of how the media accounts have developed over time, what sort of knowledge the readers, the level of knowledge that the readers are able to take in and want to hear about. Also, there was a shift towards more medical and sci expertise as a source of information. And interesting enough, also, there was an incorporation of this addiction concept so that it connected the individual problem holder for their responsibility over their own well-being and health to the societal level. And over time, this has involved sort of a shift from a view on citizens to be helped and governed in society to the individual as prime responsible for themselves, but also for the problem of society. Because, for example, if we speak of an obesity epidemic, then all people who are obese have made the wrong choices, and they then become the sum together the problem. So this kind of structural circumstances to implement help and policies moved to the background of the discussion, while the sum of the addicted subjects became the definition on the problems as a problem to be dealt with on the level of society. So this is a view that we are all familiar with it. We count the amounts of deviant or sick subjects, and it is, of course, important task to know the prevalence of problems. But what we do with this information and how we interpret it is another thing, and it is at least as much important as knowing the amount of problems. All media texts in all countries also included this kind of worry about where is this world going. And I have here in my slides, I call it the zeitgeist worry, but it's really about seeing these problems somehow connected to signs of time. We are moving faster and we are headed somewhere, which is a bit worrying. Also, there was sort of an inflation of the use of the concept. It would be used to all sorts of repetitive behaviors like watching TV, checking emails, and using smartphones. And also, there was an increase of representations of the brain as a central site and a gateway to understanding addiction as problems. So this a bit also further emphasized the biopolitics of seeing individual problematic bodies as making up the total problem. Then if we turn to the variations between countries, we could conclude that the governing images and concepts of understanding of the problems on a general level would correlate with the historically most salient question in that country. And then we could see a kind of the role division between media in the different societies. As for example, in Finland and Netherlands, there has also been known from before, the media takes on a more educating role, making people understand what the problems are all about, with the aim of diminishing gaps between different groups. While in Italy and Poland, which are both Catholic countries, the pointing out of wrongdoings and they were more advocates of solutions and also could give examples of solutions, while it was left pending in Finland and Netherlands. And also the ways in which the problems should be addressed and the repertoire of help was very line in the governing welfare system culture. I have an example here from, we have compared the US and Finland. And this figure presents on which level the media portrayals claim that the problems should be dealt with. And on the macro level, it regards society as a whole population system, and the micro level is the individual, and everything between is meso levels that can be church, community, peers, and so forth. So in a residual welfare state like the US, where these kind of meso-level help groups have been very, very important, we found that the problem was conceptualized as a problem that should be taken care of by the individual in a peer, and when the problem was dealt with, the individual had also a sort of responsibility to give back to the community and help others. Whereas in Finland, we found that either the stories would talk about a person with a problem and his struggles, and then when it was time to refer to the level of aggregation on which we would see in the society that we would deal with the problem, it was always in these quite abstract terms of the society or the system will have to deal with it. So one can see a peculiar or a typical Nordic welfare state regime and there in the background. And this is, even though Finland has a very tight AA movement and a lot of civil society movements. So the implications of these findings on the general trends in the media images, first of all, is that the political project has somewhat changed over time. And there's less structures, more individual responsibility and self-help. And one can ask, what does this in the long run imply for the kind of governance that aims at centralized, universal, equal treatment and possibilities? If a societal problem is not understood as contextual or a result of certain miscalculations in the centralized responsibility that should represent all citizens, then that diminishes the project of actually helping the people with the problems. So this is very important evidence on an ongoing conceptual change. When it comes to the implications of the variations between countries, we can see that governance relies on contact surfaces in the system, and possibilities of real change in a society must operate within these repertoires in view of the problems and their solutions. The ways in which we look at the solutions must also somehow fit, or then we have to somehow argue for them and change policies in another direction. And also, which I find quite interesting, is the role of the media and the likelihood of certain views to be represented. And this is especially interesting if you think about the commercialization of public media, for example, and the kind of formats that we tell stories to the public and how we inform them about the problems. So when it comes to the professional images, true for all materials was that all, as expected, social workers and general practitioners follow their own conceptual paths, and even the cross-cultural similarities, there were cross-cultural similarities in the differences between these two groups. But how these paths are articulated depend on the role, autonomy, and emphasis given to them in the system. And I will quickly show you, I can mention that, for example, in France, where GPs follow their patients a longer time, and they, in France you often go to the same practitioner. The general practitioner had sort of a gaze on the patient with a history, while the Finnish GPs who are treating new persons coming in on a daily basis, and they may not see these patients more than once, they were really just focusing on bodily symptoms. Whereas in Italy, the contextualization was very cultural within a sort of family paradigm. But just to show you how interesting this is, to look at differences within societies on how institutions and professions, how they embed certain views on the problems and what their tools are for dealing with them. This is a mapping of non-specialized social workers, specialized care personnel, and general practitioners and we spoke with them about eating disorders and how to treat eating disorders. Without going into the details about this, we could see these as three different paths. And as you might know, in eating disorders, it's always very much emphasized a multi-professional grasp. And as a background, we can also think that, or just think about that all European societies, especially after the economic crisis in 2008, are rearranging and transforming their welfare state systems. Institutions are merged, they are competed against each other, and there are some austerity, their resources are drawn away from certain parties. If we know the kind of content that these different institutions and professions are, their contribution to dealing with the problems, then we know the kind of pieces that we are puzzling with when we are planning our societies. So if we have this kind of knowledge, we could say, for example, if we want to draw down a budget and we say that, okay, now we are not going to give specialized care more resources, then we can see here what kind of views and kind of treatment aspects that goes with that. So this is my last slide. Two implications that I want to still present of this. As I mentioned, the division of work in a system is valued political information, how people with the problems are likely to be treated, the level of effectiveness in relation to emphasis on perspectives. We can know that if we emphasize one perspective, will it be better results? We could look at the level of multi-professionalism that we have been achieved, in case we are striving for that. And also we could look at the views that will be dominating if we divide resources in certain ways. And then the differences between professional views and institutions, between systems and the results these produce. They are also hugely valuable political knowledge because we can compare the benefits and problematic aspects of emphasizing or giving roles and autonomy to certain kind of institutions and professions. Yes, that was it.
Hilda, and do I see a hand up already? Laura.
What was the time frame for this?
For the media material, we have, it's contemporary. We have a sample from 91, 98, 2008, but then we have from before more or longer span, but it's modern time, it's contemporary time.
Because the thing I noticed, and maybe this is in the book, but the message is one part of it, but the medium is the other. And with a period like that, you've got incredible volatility in the kinds of mediums that the message is coming through on. And I'm just thinking, for example, just take the idea of a reality TV show, right? And then you have the different cultures that right? So the Big Brother came out of the Netherlands originally. Survivor, the UK, but then it got very popular in Australia, of course. And of course, the Americans, we have The Apprentice by Donald Trump. So right there, you just have captured all these cultural scripts in each one of these stories. But it's also a new medium that creates all of these potentialities. And it seems that you have such a wonderful opportunity to think through, maybe this is a second book, to think through all of the evolution of all of these new forms of communication and how the cultural variations played out. I mean, it's a very complex terrain that you're navigating here.
Yeah, that's true. And I think I'm going that way also.
Okay, I think we have a question that's come through from outside. All right. Do you need a microphone?
Well, I've got I'm Julie Reynolds from the SRAP coordinating team. It's more a question or reflection. Have you considered approaching the media to speak to them about which is their role in defining addiction and how they influence this concept?
No, I haven't done that, but no. Just I've sometimes discussed with some journalists or something, but I've never studied it, no.
Because it's more in the sense of seeing them also as a stakeholder in this process.
Absolutely.
It could be something worth.
And that was a
looking
stakeholder
into.
group that also, when we looked at who was the source of information speaking in the text, and actual media was increasing.
Yeah, the source.
Yeah, a source of information.
Any other comments? No, Peter.
Matilda, can you give me then your one sort of headline statement of how does this help us with better governance?
Well, if you speak about the media, I think it helps by the awareness of the media role and how it's affecting our perceptions. But when I feel this other study, I think it's helping governance, as I said, by giving us the opportunity to see the content of what is not only what we are doing, but what are the views and the cultures involved when we are approaching people with these problems. So, and then also one thing that could also apply to the whole area is that the views on the problems, how we understand them, they affect actually the actual problems. They are the problem, because you cannot start doing something if you don't have a vision of what that will give you, or you know that that will give you something like the monkeys that you talked about this morning, about they were feeling and smelling the fruits. They had an idea in their head what the fruit would do to them. So the activities are in themselves socially learned.
Robin.
It's really interesting that you talked about the shifts from a social framing to an individual problem framing, and I think you were presenting that as being something that you saw across the different societies. And I was wondering how much that reflected a shift in balance of power between popular and professional narratives, or were they both going in the same direction? What's going on? You know?
Actually, when I said that, I was referring to something, to the analysis where we looked at the source of information.
Okay.
And there we had different groups. We had expertise in different areas, and then we had the media was one group, the problem holder themselves, and there we could see this trend of depoliticization, that it was not a political matter, but more framed in a story about something else.
So that's a trend over time, you're saying, that you were saying?
That was a trend in these sources.
In the sources?
In the sources, yes. But it's really more complicated than I'm saying now, because, for instance, in the Italian material, there were other kinds of developments, but this was, the depoliticization was at least something that we could say for all of these countries.
So on the one hand you have a depoliticization, and on the other hand you have a broadening of the addiction concept.
Yes.
Are those two related, do you think?
They are definitely related, because this is what I've also been studying from the 60s to today in a very big other media material. And actually when the addiction concepts come into the picture,
so the addiction concept individualizes the problem.
Well, that is what I can say on the basis of my own research.
And takes attention away from the collective level. Is that
the collective level?
What you're saying? Yeah, right.
I would say that.
Thank you.
And did you want to? Oh, you want to? Would you like to?
I
agree. You say who you are as well,
yes,
please?
Joan Villalbi from Barcelona. And you seem to reflect how the media shapes the visions of addictions and how this has a huge effect on the policies that are possible because the public opinion conditions it. But also, I think we learned in Spain, for instance, how to change the media narrative for smoking to make policies that prevented smoking possible. And from an alliance of professional organizations, we were able to change completely the way smoking was dealt by the media from an individual issue related to freedom into something that was shaped by the powers of the industry and that needed health protection. And I wonder if you found some of these in any of the countries and the issues you've been dealing with.
We had an interesting case, which I'm afraid that we never published, but we're working on it. And that was in the UK when there was a policy change on, it was forbidden to have any commercials. It was, I think it was in all media, yes. And we studied, or it was my colleagues in the Stirling University who studied how the media images looked before and after. And actually, there were more images of smoking after the before, because they were just channeled through other sorts of stories. So there's a change of stories, of course, yeah. But this would be, if you mean how we can affect the media stories, then I would say that it's important actually to speak to media representatives and remind them of the influence they bear on how we understand these problems.
Okay, I think we've got five to 10 minutes. What I'd like to do is to invite the other two speakers to come up here, and we'll throw it open now to more general discussion about some of the issues which this session has raised. And I think they'll need microphones, I guess. So if you want to...
could all huddle.
We could also stand.
We could huddle.
Oh, you're going to stand up there? Okay. Okay, so... do you want to sit?
It's so small.
Right, we've got trio over to my right who are available to comment on the issues which this session has raised about the historical, well, in a sense, the social context within which the important, if not the dominant, dimension, in a sense, of what we're talking about. So, would anyone like to make a comment, or would our concepts and the responses which we've been talking about today take place, and how those change over time? Which is, and speakers like to comment on anything they've heard so far? Yes.
Just a question. Oh, yes. Just a question. The degree to which science is infusing itself into these perceptions, particularly in medications development, there's clear evidence that there's certain medications are very useful, particularly in opiate addiction, I think to a lesser extent with alcohol. Just curious to what degree this is infusing itself into the public perceptions and media.
You mean the role of science in terms of...
findings from specific studies, treatment outcome studies. There's been a lot of treatment outcome studies, psychosocial treatment.
You're talking about in terms of the media, or in terms of...
how those findings are reflected in
the media
portrayals.
Okay, that's one for you then, Matilda, perhaps.
At least in later years, and now it's quite usual that media portrayals go into quite detailed. An example is a study, an analysis that we did also in this project about how tobacco has been portrayed in the media as a problem. And there, the kind of these kind of elements come into the pictures with very detailed medical expertise. And this also resulted in a huge popularity. I don't know if it's a result of that, but at the same time there was a huge popularity of products like nicotine plasters and these kind of technical details that came from the medical industry or the pharmaceutical industry. But it's hard to see. It's hard to speculate about the background sources, but there are, of course, some sciences that are more easy to translate into a good media story. And often they are these so-called science fictional stories that this is going to delete the problem.
Mm. Would you want to comment on the role of science?
That would be a massive question, I think. Obviously the science matters, and the science has changed over time. But I think that the politics, the society, the economics, the culture matters too. And I think we need to kind of put all of those things into our picture.
Robin.
Sorry. Just picking up on the last little exchange with Matilda in a more general sense, that you found, if I understood it, Matilda, that the addiction concept, invoking the addiction concept, essentially went along with an individualizing of the problem, which is what I would often expect to see. But if we think about the tobacco history, in a way, didn't that go the opposite direction? That in a way the addiction concept was how the public health folk made it into a social problem and something that had to be dealt with at a level beyond the individual? Or, in other words, does the addiction concept always point in one way or another in any of the materials that you were looking at? Or can you see it pointing in both directions?
Well, these detailed questions are very difficult to answer, but I would say that the tobacco question, when looking at the development of that question, it was unique, and there was some consensus between different levels and stakeholders that made it progress in the way it did. And also, I think that when you make a distinction between individual and society, it's not the kind of policies that are governing societies and often construing social environments in which we are to implement policies. They are today articulated through the individual, as we say in biopolitics. So it's not, it can be social even though it is individual. So I would say yes, it points in both directions.
We've got time for one more. That's right.
I'm Lidia Segura from the Program on Substance Abuse of the Health Department in Barcelona, in Catalonia. Well, having done all these analysis from historical perspective, narratives and stakeholders, what do you think that the concept of heavy drink consumption over time brings to this scenario? And do you think it could be easily adopted from having in mind all these perspectives?
Please.
Feel free. Well, I think the history would show that you could see this as the latest in a long line of different concepts that have been adopted and created and used over time. And I think that this would lead into the other presentations too, is about what's driving that change and what are the actors involved in that process. So I would say that the historical perspectives gives us this sort of longer lens to look at that. As to its success or otherwise, I'll pass that on to my colleagues.
I think that would be one of the ways we would probably all want to turn some of this discussion towards our audience today, because it's fascinating to see this new concept coming on the block, this new idea. And for historians, and I think policy analysts and others, the first thing we would ask is, well, what's driving that? Who are the interests? What interests are at stake in all of this? So it's a very interesting example, though we didn't study it, of historical and stakeholder analysis, in a sense.
Fits very well to the general trend toward individualization and depoliticization of addiction. Because it really reduces the question to individual level, but perhaps I am mistaken. But it is what we found out in the recent trends, the trend toward individualization and depoliticization of addiction concept. And if we say that it is not a question of structural deficiencies, but just a question of that somebody drinks more and even more over time, then we actually fit well this kind of definition or public portrayal of addictions.
Anyone want to come back on that before we finish?
I think I agree with the point that was just made, and that is that, you know, the focusing on just the repeated behavior keeps the focus on the individual. And I didn't get to make this comment when Peter presented, but Peter, you presented a slide when you presented heavy use over time that had huge error bars in it, and it was basically the relationship between addiction, like diagnoses, and quantity of use. And at the end of the slide, you had, like, it was a very nice relationship, but at the very high levels of addiction, you had huge error bars. To me, that means that there's a lot of variability. And Jürgen and I have had this conversation before. There are other studies suggesting that, like, yes, 50% of people who would be classified as an addict according to clinical diagnoses could be classified based on a frequency of use measure. But there's still 50% of the variance that's accounted for by other things. Those are your error bars. And it's all that other stuff that isn't the individual. It's not the behavior. It's the social and political and all the other determinants that exacerbate the problem, that make it more of a problem for the individual and their environment. And I'm just not sure, heavy use over time is capturing all that other variance in your slide and in this discussion.
Peter.
I think those error bars are just a fact of small numbers at the heavy end. It's nothing more than that. Sorry?
It's still true though. You've got a lot of error.
And we've got a comment coming in from the back.
I wanted it to be true. Oh, sorry.
This is just one last question that's just come in online.
Yeah.
From Franca Beccaria.
Oh yes.
In Italy.
One of our team.
Yes, she's saying, I've been part of these studies and found them very interesting and important for the scientific scene, but nevertheless I feel a little bit frustrated as it seems not so easy to produce a simple message to take home for Alice Rapp. Which are your feelings about these?
Not so easy to make a simple message.
A take-home message.
Well,
she feels frustrated.
I
think it's very simple.
There's not a simple message in terms of something that's going to solve something, but I think there's a message to make you think and to make you pause before people go down certain routes or do certain things, to think of the context in which people are operating, both now and where we've come from. But my colleagues might want to add to that.
Yeah, I would say the same. You can say it in 2 words, and it's context matters.
Yeah, either in the past or in the present.
Yeah.
And who's defining as well.
Yeah.
I mean, for instance, is heavy use over time the advent of public health people taking the scene, for instance? Or?
Yeah. Well, these are all things to be discussed, and I think we have to finish this session now. But Franklin, you want to?
I just didn't want to lose the point you made, Virginia, that I think was really key, was that, to me, one of the take-home messages from this session and these studies is the fact that, yes, context matters, but, getting an understanding of who the change agents and what are the drivers of change. And I think the message I'm hearing is, in terms of Alice Rapp and our effort now to be taking action in terms of reframing addiction, I think that one of the things we've noticed is that there's actually a great diversity in terms of the sort of perspectives on addiction in this room here, and even greater, across the period of time of the project and stuff. And as we come up with sort of a unified message and frame, that I think that we have to get a little more clarity about who we are in terms of delivering those messages, and we're advocating for certain, I would assume we're going to end up advocating for certain approaches. We're going to, we're not just giving a general blah blah, here's 8 books of information, use them, we have come up with 10 points of a 10-point plan with key messages and stuff, and to the degree that we are together in advocating for that, that's where I think some of the challenge lies, and I hope we'll take that up in the last session as well.
Right. Well.